Okay, thanks everyone for joining us for another edition of Discussions in Diagnosis. It's a real pleasure to welcome Mary Dolansky here this morning. She's the Sarah Hirsch Professor in the School of Nursing here at Case Western Reserve, as well as an Associate Professor in the Department of Quantitative Health Sciences at Case, and also helps run the VA Scholars Program. So she's very busy. We're here to talk today broadly about team-based approaches to diagnosis, and specifically the role of nurses. So we're going to share a couple of anecdotes, and this is often presented to us as something new, but nurses have been informally involved in diagnosis for a long time. So I can date myself and say that when I was a third-year student at the Montreal General Hospital at McGill, in internal medicine, our senior resident actually set a really good example for us. We would round on the patient with one of the nurses who was responsible for that floor, and he would ask her every single time, well, what do you think about how she looks? What do you think is going on? And her insights were spot on most of the time. The other example I can give you is from much later in my career, when I was an outpatient physician in a practice in a underserved area in Pittsburgh. And one of the nurses I worked with closely there had great insights into the patients before I saw them. The reason for visit might have been physical, or it might have been checkup on diabetes, but that she would say, did you know that her brother just died and it's just been really traumatic, and that might explain what's going on. And so I got into the habit of actually asking her. So I think the principle is nurses often have much closer contact with our patients than physicians do. And also, because of their experience, they have a lot of clinical skills that can contribute to diagnosis. So thank you, Mary, for joining us this morning. With that preface, there was a 2015 National Academy of Medicine report on diagnosis that recommended a team-based approach to diagnosis, and these figures have been widely shared. And a team-based approach doesn't just mean physicians and nurses, of course. It means patients, it means families. But let's talk specifically about nurses. How do you see their role in diagnosis?
Sure. Well, first, as you all know, there's many types of nurses. We have nursing assistants, LPNs. We have, RNs who are associate degree and baccalaureate prepared. And then we have doctorate of nursing practice. So there's a lot of different types of nurses. So just keep that in mind, I think, when you are working with nurses. But historically, like in the 80s and 90s, when I was becoming a new nurse, and even since then, we were trained not to diagnose. Like, we were trained that that is not a part of our scope of practice. And so there was this huge initiative with this nursing diagnosis, which was more connected to symptoms and how nurses could diagnose nursing phenomenon. So that is a little bit of a barrier now, because I think we're still enculturated in nursing to not use that word diagnosis. And I also led the Cusin Institute, which is Quality Safety Education for Nurses. And Chris Goschel, who is a nurse who's been leading the AHRQ team steps for diagnosis excellence and accuracy, she reached out to me to say she wanted to present at Q's. And I was like, well, why would we be, as nurses, interested in diagnosis? But that really opened my eyes to this whole area, that it is a part of safety and that we really need to have this mindset of teams. And that new mindset is really that the role of the team is in a diagnosis, and that we have to communicate and all share our findings and really get together to share all of our observations so that we can come to a clearer picture. I was recently a part of the sepsis team, where we went to a local hospital here in Cleveland, and we used human-centered design principles to learn about sepsis. And one barrier really was this whole lack of kind of a standardization about what we mean by kind of huddling together to discuss diagnosis. It really, although they did communicate back and forth, it was not like labeled as, okay, we're kind of getting together to get at a clear diagnosis. And I kind of think that language would maybe help us a little bit in our future, working collaboratively with teams and other professionals, because all our contributions, I think, lead us to a better diagnosis, specifically in sepsis, and really saves lives. So anyways, I think that just to be clear in labeling what we're doing collaboratively would be, I think, a big help.
Yeah, that's a great point. I mean, one of the terms I've heard is, hey, as a team, we can get a better picture of this patient. So that kind of
Mhm.
takes the stigma around diagnosis a little bit out of the picture. It's okay, we want a picture of what's going on diagnostically with the patient, and welcoming everybody to contribute to that, every member of the team, well, whatever role they happen to have. So thank you for sharing that. So that brings me to some broader questions. Because of this Institute of Medicine report, because of this new emphasis, clearly schools of nursing have to adapt in terms of their training. And nurses who are in practice, who are the vast majority out there, also have to adapt. So what is going on in terms of training nurses to adopt this new approach?
Well, the Future of Nursing report by the IOM also was a big call out to include the team-based approach to diagnosis. But I can probably say it really hasn't hit the nursing curriculum to this point, particularly in those words, in the clarity of what this is about, which is team-based diagnosis, getting that full picture. So we're just not taught about it in those words. And then we really are not taught about the value of how much we can contribute. Now, probably in the ED and in critical care, nurses are probably more collaborative and team-based in this, movement. But we probably need to expand to the education of the next generation in this concept. There's a lot of barriers, that we know that we probably don't address either in education, like psychological safety, helping nurses to feel safe to speak up. And there's a lot of evidence and stories that we have gone through, like the Lewis Blackman story about how the nurses were like afraid to speak up. And, Lewis Blackman and with Helen Haskell's son, did pass away because I think that there were these barriers with kind of team thinking on the condition of the patient. I think too, for the training of the nurses, what we found in the ED that all the providers and the medics all said, like, the key here is the nurses. They really in triage, they really see this early on and they really communicate well. And I think there's a lot of merit in acknowledging the nurses and then also integrating it better into our curriculum. Because I think that is a key piece here that we need more work in. And, now I think now that there's these competencies that we can integrate, and I think that is going to be a little bit of work.
Absolutely. Okay. Well, thanks for sharing that. So here's another significant barrier. So we talked a little bit about training. We're it sounds like in the infancy of training nurses in this new paradigm. It's going to take some time to get this into schools and et cetera. But the other thing I often hear, and this is true here in Cleveland, it's true across the country. First of all, there's a severe shortage of nurses, as you know. And the nurses that are able to work in our institution, for example, are often overwhelmed. They're looking after more patients than ever. They've got all of these responsibilities. And then for me as a physician to go up there and say, hey, you just saw Mr. Smith. I'm just wondering what your thoughts were. How does he look compared to yesterday? What's going on? That's not easy to do in that environment. It's hard enough for physicians too, because we're also overwhelmed. So how do we overcome that barrier? Because that's often cited as a problem.
Yeah, and it looks like my camera froze a little bit, but can you still hear me?
Yes, we can hear you.
Okay, great. So I think this is a really important point, especially with the travelers. I think there is a bit of swift trust that needs to be addressed in the work forward in kind of trusting that collaboration. We are all busy, but I think the busyness and the lack of pause and the lack of pause to hear everyone's views is the culprit of our safety issues.
Mm-hmm.
So I think we just have to make the time to huddle, collaborate, communicate, and prioritize the collaboration. Because I think we do know from all the medical claims that the safety is at risk here, and that 30% of these claims find that nursing was a part of and responsible for the misdiagnosis because they didn't communicate. And I just love the approach where you go to the nurse and ask for their perspective. That's a very important, I think, reach out. and really would help to facilitate more communication and trust and psychological safety. We want to work to the top of our extent of our license. And you're right, that short staffing really is a big problem for us, that the system doesn't support us in our work. But I guess, as a team and as healthcare professionals, we have to just be loud and step up and tell our administrators, that we need more time in some regards to do these steps that are essential, to prevent errors. I think also about the Chinese parable of the elephant and the different healthcare professionals sort of as blind on the elephant, and where they kind of say, well, what does the elephant look like? And every one of those kind of Chinese, or it could be healthcare professional who's kind of blinded, explains the elephant in their own way. Like the elephant is like stringy, the tail, and the tusk is sharp. But unless we can communicate together, we just don't get the full picture, like you said.
Right. Absolutely. So you raise a really important point, and that is kind of formalizing this team-based communication, which I think is a priority. And obviously, you're doing that with the huddles, with Dr. Goldstein, Dr. Macias on the pediatric end, et cetera. So team steps is, of course, a paradigm for improving interprofessional communication. And I understand, Mary, you've got some information to share about team steps for us.
Yeah. So it looks like my video got a little bit lagged, but I'm hoping I'll still be able to share my screen.
Sure. Try hitting share screen.
Okay. Yeah, gosh, darn it. It looks like I've got Zoom problems.
Okay.
So I'm so sorry. And I should have sent you the slides earlier so that you could have shared your screen, but I'll try to set, how about if I send them to you quickly here, and maybe you can
Sure.
share your screen.
Yeah,
Okay.
let's
So
pause our
sorry.
record.
All the initiatives. So just to kind of cue you up to the Team Steps website, which can be found, at the AHRQ Team Steps site, they have a lot of different Team Steps modules, a generic one, and they have one for rapid responses. They have one for ambulatory care, dental care, long-term care, and then office-based Team Steps. But they just came out last year with the Diagnosis Improvement Team Steps module, which really makes a lot of sense, kind of what we've been talking about, how important it is for us as healthcare professionals to work together as a team. And they have a really nice module and setup for training. And they really emphasize that the patient needs to be involved in this diagnostic team, because they're going to provide information that's going to be critical. The front desk person maybe even might have some information, or the cleaning people. The nurses, they, as Dr. Rose said, they're there with the patient 24/7. They hear a lot. They're have the time to be at the site of the patient and gather more information that could be possible. And then the pharmacist. So many people are involved in this, team-based approach to diagnosis improvement. The Team Steps is all evidence-based, and it really helps to promote quality, safety, and efficiency. And their tools are very practical and very adaptable. And their modules are easy to use, but I think, as Jessica said, they're time-consuming. But I think other ways of delivering these might be of use for us. I think that the Team Steps really focuses on communication and the skills to ensure that we have high reliable care delivery, specifically in collaborative diagnosis. And again, in all these, teamwork is really the key piece. So they have these modules that can be delivered that talk about the diagnostic team structure, communication, leadership, situational monitoring, mutual support, and then kind of pulling it all together. And then they have an assessment tool, which is really very beneficial, where every team member can assess their skill and their knowledge in the collaborative diagnosis. And then they also have a reflective practice tool, which is another really important tool to help. They give a couple of case studies, and all these modules really, I think, enhance or facilitate good competence. They also include a nice facilitator guide that helps to guide
the teaching of this to the staff. And then they also have like a participant workbook so that the participant can follow along and kind of reflect on their own kind of note taking. And I think that's the key here on the AHRQ site. So thanks for showing the website.
Sure.
Is really the system part of the what's in between the patient and the physician, or the patient and the provider. That there's a lot going on in that system in between, and a lot of people and a lot of voices that really can be empowered to help to contribute to accurate diagnosis. And again, I really think that I know you probably have seen that figure of the rabbit where you look at it one time and it looks like a rabbit, and you look at it again and it looks like a different figure, or the other one where it's a woman, but then when you look at it a little differently, it's actually a witch. And so I think that this is really what we need in accurate diagnosis, this kind of reflection, personally, then reflection with the team, so that we can flip our lens to really see the full picture of a patient that's in front of us. So that reflection piece is really key, where you ask yourself, what's my role in helping to achieve a good diagnosis? All team members to ask that. And then all team members to really listen to the team and their unique perspective, and then to act in ways that can contribute to that diagnostic process. So I think if we all as a team ask and listen and act, and I think respect each other, we will get much farther in accurate diagnosis.
Thank you, Mary. And I think that the takeaway, I think, is that we have to be proactive in promoting this new approach to it. So in other words, asking our staff, whatever their background is, and maybe even relatives, patients, et cetera, what their thoughts are about diagnosis. And that's certainly the direction that things are moving in. Okay, well, thank you very much. Any additional questions before we wrap up? Okay, if there are no additional questions, thank you to Dr. Dolansky. Sorry about our technical glitches this morning, but they seem to happen pretty regularly. And everyone have a wonderful day and wonderful weekend. We'll see you next week. Bye-bye.
Thank you. Bye-bye.